So yeah, I'll introduce Ian. He, as everyone knows, podiatric surgeon based in Northamptonshire. Most well known potentially within the audience here for his steroid injection course, or sorry, his injection course, which is going to be the main topic of discussion this evening. To get us going, I'm just going to share my screen, if I may, and by way of sort of commencing the discussion, just I know Ian's aware of these papers already. Just talk about a bit of the evidence, and then talk about, I guess, about evidence versus clinical practice and clinical outcomes. This Cochrane review from 2015, which was talking about injection therapy, so not just corticosteroids, but injections in and around the Achilles for tendinopathic Achilles. And we conclude here, insufficient evidence to draw conclusions on the use, etc. Next paper, again, Cochrane review, 2017, much more recent. This one on corticosteroids for plantar heel pain, and low quality evidence and further research required. And then this, just from last year as well, much more of a sort of case review type of paper, not the kind of level of evidence of the Cochrane review, but talking about how safe, effective corticosteroid injections can be, that they can potentially, reduce the need for surgery. So a bit of a discourse there. And I just thought it might be a reasonable starting point to sort of springboard from. Let me unshare my screen.
Yeah, so evidence-based for steroid therapy is pretty bobbins, actually. So for my master's, I did injection therapy for plantar fasciitis, and I did a review of the literature. Ended up with about 200 references, the majority of which were along the lines of, I injected 10 patients and most of them got better. So kind of level 4, level 5, and that's obviously what the high level studies are saying. So there's a lot written, but the quality is really low, and we all love to get that level 1, level 2. But I guess we'd accept, just because it's not been shown to work, evidence of outcome is not, outcome of evidence. So let's talk about plantar fasciitis, because that was the thing that I looked at the most. So if we're thinking about a paper on injection therapy for heel pain, so question 1 would be, we're dealing with plantar heel pain. Are we dealing with plantar fasciitis, or are we dealing with other pathologies? As somebody that sees heel pain a lot, and I'm sure you guys are the same, when you see lots of heel pain, you'll see plantar calcitis, had one today, so a true policeman's heel. You'll see nerve entrapments, you'll see tarsal tunnel. So my first question with the papers is, how accurate is that diagnosis? Have they all been really accurately diagnosed with an ultrasound? You then come to the choice of injectate. I can't tell you the regimen for plantar fasciitis, that it's this drug, this amount, from this approach, with this follow-up. So there are 3 approaches commonly written up for heel pain. There's a plantar approach. Look, I have a model. So that nice plantar, a la GP, which hurts a lot. There's the medial approach, which is the one that I will tend to do, going in, that's a little kinder. And there's even a posterior approach. We believe there's actually people coming from the back of the heel. So what technique is best? What drug? How often do you follow? My real question is, where does the injectate go? Does it go below, above, or in? And then you take it to that as a jobbing clinician, and certainly a pretend researcher. If you've got somebody who's got an acute plantar fasciitis and you've had it for a few weeks and it's really quite inflamed and it really is an itis, and then you've got somebody else who's had it for 5 years and it's an osis, and you give them a shot of steroid, how can you put all those patients into one group and say, this is the effect of steroid? So the clinician in me would say, most of the studies, you give 1 shot of steroid, you try and single blind it and just have 1 intervention. But clinically, when we deal with heel pain, we're going to do some padding, we're going to do some stretching, we're going to do some steroids, we're going to do some surgery. So I think it's very difficult to prove what the steroid actually does. And clinically, I just don't know how many people would say, I'm only going to do a shot of steroid and that's it. And that's just not what we do in clinical practice. So I think the challenge is to show where it's effective. Doesn't really answer your question terribly.
No. I mean, it does. I mean, ultimately what we're saying, like most things, is we'd always love more evidence. But,
sure.
What we have plus good history, sound clinical reasoning is absolutely fine for the current status. I mean, that's the same in most things we do, I would say.
Yeah. But the quality is really, really bad. So when I run my courses, this is not a plug for my courses, but thank you for that.
Well, we can do at the end.
So I have a whole section on the evidence base because it's really important that you apply what's out there. So what I kind of figure broadly, my limited experience of doing a few injections, is that they're very effective for plantar fasciitis, sooner rather than better. 50-50 maybe. Not so good for Morton's, but better for joints. So one of the questions I think that's coming in is what are the main things that we inject? So they are plantar fasciitis, hallux limitus, and a Morton's neuroma. And so I feel, having audited my own work, 80% of patients do well with hallux limitus injections. The less arthritic, the better, and the longer that will last. But again, there's one thing I always stress, and anybody who's been on my course will tell you I stress. The injections are not a magic bullet, so I always think conservative options, injection therapy options, and surgical options. You can play those around a little bit. So don't just give somebody a shot and go, there you go, happy Christmas, see you in 5 years' time. It's how you manage all the other things. If you've got a bent for biomechanics, for instance, then you might want to give them injections, settle down the pain, and then do something to, I was going to say control function then, but
You've actually answered two of the main questions that came in beforehand. One was along the lines of what are the top 3 pathologies you inject, which I think you've pretty much answered. And the other was, what's your sort of protocol for how you decide the timing of an injection within the multi-modal approach? So again, I think you've probably touched on that as well. Just picking on something you said when you said first MTPJ, Morton's, and plantar heel pain. This is all corticosteroid?
Yep.
With first MTPJ, you ever play around with cocktails of Ostenil and things like this?
Yeah, absolutely.
What's your experience with that?
So the evidence for the HAs, the high hyaluronic acid, is fairly weak generally. And the evidence that's out there is better in the knees than the toes. My overall cocktail of how I play with things is again, conservative injection surgery. That's going to be, for everything that I do, that's pretty much going to be the plan. Now, I might have a patient that turns up with a really acutely sore toe. So you might go in early with a steroid, which will loosen up the joint, settle down the worst inflammation, and then you might go in with an orthotic. Sorry, arch support. Excuse me.
You tinker.
So one of the things a steroid might do will be to settle down the pain so you can go in with another treatment, whatever that is. Broadly then, in terms of the different juices, I'll use a steroid first to settle down the worst inflammation, and then I might then go in with some HA, which acts as a little bit of a lubricant. And we've just got a new one on the market called Durolane. I'm just about to start a trial of, which is a slightly higher Newtonian molecular weight and apparently a little bit better. So I'm quite a fan of HA. I go through phases of using it, but I think there's some use. The evidence isn't great, but you've got something that's a natural substance. You're not going to do any damage. You're not going to do any harm, whereas with steroid you will. And it's another option, and it's useful for those patients that don't want surgery for whatever reason. So I'm a fan of the HA.
Actually, Ian, can I just go back to something you said earlier on? We have had a question come in related to that. You talked about in some of the clinical trials, if all your plantar fasciitis are the itises and you inject them, you get a certain result. If they're all the osises and you inject them, you might get a different result. And that there's 3 studies in the patellofemoral pain literature that I like citing, and these 3 studies looked at clinical subcategorizations in patellofemoral pain, and they speculate that the outcome of a clinical trial might depend on how many of which type you get in your clinical trial. Mm-hmm. So it's the exact same issue, that there's obviously a whole lot of subcategories of plantar fasciopathy, and based on just the thickness, the amount of the hypoechoic signal, et cetera. So if you did a clinical trial on injections or orthotics or whatever, and all the participants had a really real strong hypoechoic signal, you might get a different result if that signal was a lot less. Now, so what I ask is that if you want to disprove or prove something, it could be dependent on the nature of the subjects you recruit, which sort of leads into a question I was going to ask, which was, and there's a question from Angie along the same line, is what are the criteria that you use to decide? Are you using diagnostic ultrasound to look at that hypoechoic signal, perhaps, or something like that? Now, the exact question that Angie asked was, at what point do you give the injection? So it's sort of along the same line. So how do you decide? This one's probably going to respond well. This one's not going to respond well. The potential of subcategorizations and those kinds of issues.
So as with everything that we do clinically, it's a real mixture of art and science. And I think with the injection therapy, it's much more art than science. I've got a colleague with me at the moment who's coming through for some mentoring. And while it's actually, I think, relatively easy to teach the technicality of this is where the needle goes, I spend a lot more time talking about when we're going to inject and when we're not going to inject and why. And that's before we even get into what compound, how much, how often. So let's come with a real case. Should we stick with heel pain for the moment, Craig? If we stick with the heel pain, okay. So back in the day, I'd get a patient with plantar fasciitis, and it would look like fasciitis and it would feel like it. And I'd typically, ideally, as a jobbing pod surgeon, they'd come through to me having had a period of conservative care. So the majority of patients, I'm going to do something conservative before I jump in with an injection. So that might be stretching, it might be heel cushions. In my particular world, I'm limited to what I can do in terms of orthotics just because of local politics. So, but they'll typically have a period of conservative care. I'm a big fan of heel cushions. That for me is kind of one of my go-tos. And then it really depends on the level of pain. If you've got somebody who's really acutely sore, then that steroid going in early when I think it's an itis, and I'm convinced that you get an itis in the early days, then I'll often go in to treat the acute pain. Later on down the track, then I'll be looking to scan, and certainly ultrasound has really changed my practice in the last sort of 5-6 years. Locally, we used to have difficulty getting access to ultrasound, and as you know, it's very operator dependent. We've now got some excellent radiologists working in Northampton, and when you have guys you've got real confidence in, you're very quick to send for injections. And what's amazing is when you send off to a good radiologist is how many actually come back as negative. So you scan them and it looked like a fasciitis, but actually the fascia is normal. And then you kind of go back and look again and go, actually it's a little bit more like a tarsal tunnel or a Baxter's nerve or something differently. So I guess to roundabouts answer your question is, I'm scanning and I'm x-raying much more than I used to. And also within the environment that I'm in, I work in a couple of private hospitals. What I'll often do is I'll get the radiologist while they're scanning to inject at the same time. So they're doing guided injection therapy. So if I take plantar fasciitis, I think I'm about 50-50 with the injections. I think half the patients I inject, I get better. And that's all they need. Maybe with some padding.
Is that blind, Ian, not guided?
Yeah. So that's me doing it. So I'm about 50-50 with a little bit of conservative. So the radiologist, when I send them to the radiologist, I'm going primarily for that diagnostic scan, look to see how thick the fascia is, make sure we've got the right diagnosis and exclude other problems. And then I'll get them to do a guided injection. And they're about 60-40, so they're getting better results than I am, guided, than me doing it blind, which kind of makes sense, doesn't it? So I'm really cool with that. Plus, I'm not the bad guy. I'm not the one giving them a painful injection. And if the fascia ruptures, again, I'm not the bad guy there. So sorry to interrupt. What does the literature tell us on guided versus blind injections? Is there much literature out there on it? There's a little bit. So there's actually some really interesting literature just to show you, first off, where the injectate goes. So when you actually put something that's a bit more labelled and you put it in, you think you're putting a little smidge in, but actually it spreads up to 5 centimetres. So, quite an area. And that's where you see, I had a lady back today, dark-skinned. I'd done a first MTPJ injection for her 6 weeks ago, and she had a big, nice white patch, same colour as me, all the way up the metatarsal. It spread 3-4 centimetres. And that was a joint injection that had come out of the joint and leached. So the injectate does spread around quite a bit. The evidence is a little bit weak, but it's mildly in favour of guided versus non-guided. But for certain conditions, like a Morton's, it's so far distal, I don't think it makes a huge amount of difference, provided you're not dealing with a bursitis. And there it's nice to really target either the neuroma or the bursa.
And you talked a bit there about sort of skin discoloration, and I know in the last few minutes that we've talked about things like tissue rupture. Let's move on to risks of injections, which I know you talk about heavily on your course. The big one that everyone always talks about is rupture. From my perspective, at least, plantar fascia rupture, or you inject near a tendon like tibialis posterior or the Achilles, they're going to rupture. And I looked into the literature, and I really just can't find that much. It doesn't feel like this big sort of concern that everyone makes it out to be. I mean, that may be because of my look at the literature. I mean, what's your take on it?
So the key paper that everybody references is Acevedo and Beskin from about 20 years ago, and they're using triamcinolone. So I always say to my guys, triamcinolone, Kenalog, keep that away from soft tissues. It's equipotent to methylpred, but it's a fluorinated molecule. So in vivo, it's just a little bit more active. So I keep Kenalog for joints, and I use methylpred or hydrocortisone for soft tissues. If you look at the paper by Acevedo and Beskin, where it talks about 10% rupture rate, if you actually look at the maths doesn't stack up real well in the paper. So that's not great for one. And most people who read about it will say, do you know what, I think it's an over worry. And certainly some of the American papers, they're using even stronger, more potent steroids. Surgically, one of the things I do for plantar fascia is cut the ligament. So actually, I think when we get good results, we actually get a mini rupture. The secret is to do it in a controlled measure. So my technique for fascia, as I've developed over the years, is I'll use methylprednisolone, 40 mg, quite a decent dose. I'll do it from a medial approach, which is a little kinder, and I use it with peppering. So I go below the ligament, above, and all the way through it. So I'm really looking to break down that thickened fascia. So I think clinically I'm getting better results with that in a non-scientific way. But I'm probably seeing a few little ruptures in there. I've never knowingly seen a rupture of my own. But I think causing a few ruptures is actually how they work.
Interesting. So from a biological and chemical perspective, what we know about the tissue and the chemicals within the injectates, it makes sense that rupture could and would occur.
Yeah.
But it just doesn't seem to be happening with the rate that the patients are reading about this online, aren't they? Oh, I don't want to inject. So there's this discrepancy between what people believe and actually what's going on, but there is some truth behind it. Is that the summary there?
Yeah. So case in point, had a patient turn up for surgery on Friday. She'd had an injection done by my radiology colleague about 6 months ago. Had gone on to develop a partial rupture that had been painful. So she was coming along to have surgery. So we were going to have something called topaz, which is coagulation, the idea of being converting that chronic inflammation into an acute inflammation that would heal. Turned up on the day of surgery, and I'm marking her up, and I said, okay, then Gladys, where does it hurt? She said, oh, there's no pain. She'd gone on to a full rupture, and guess what? She's now asymptomatic. So no surgery for her, and she was discharged.
I mean, I've definitely seen a couple of cases where people have had tissue ruptures after injection, but I personally, when I listened to the story, didn't blame the injection. So the one that always is in my mind is someone that by the time they got to me, the first time they were sort of told it was a consultant orthopedic surgeon, foot and ankle guy, who basically said tib post had a partial tear.
Yeah.
Some of the, there was some tenosynovitis, so we're going to pop some steroid in there. And after they did, they were completely pain-free.
Yeah.
And what they did after being completely pain-free is what any runner does after being completely pain-free. And they massively spiked their load because they were pain-free. And they went on to a full rupture. And I think the very valid debate here is, did the steroid cause the rupture? Or was it just that they put a massive amount of load through something which had half its cross-sectional area? Now, they wouldn't have done that were it not for the steroid, you could argue. But these are the ones that I don't want to be anywhere near court for.
So here's point number one. I always say to the guys I teach, any joint, and it's the same in orthopedics, and we've really got to mirror them because they're the standard. So any joint you want to inject, you should X-ray first. Any soft tissue you want to inject, you should scan first, and that's becoming the standard practice. I mean, I don't always follow it, but it's what I always say. But absolutely, I would not put steroid near a tendon without a scan first. And I have ruptured 2 tendons 10 years ago, not great. So you kind of learn by your mistakes. So absolutely, every single tendon is getting a scan first. So if I'm seeing stage 1 post-tib, inflammation, no partial tear, then I'm kind of happy to put in a small dose under ultrasound. So in actual fact, I'm not doing the injection. Usually it's the radiologist. And then they need protecting afterwards. So he had the experience of, as a consultant radiologist, injecting his colleague, another consultant radiologist, Achilles tendinopathy, and it literally popped before he got to the car. Now, I don't know whether so the steroid can't have done it in that time. It's not going to knock out the tenocytes. So what you are doing is potentially some needle trauma and potentially just taking away that protective pain threshold. So any big tendon I'm injecting or prescribing an injection, they're in an air cast boot for 2 to 4 weeks. It's somewhat defensive practice, but again, I think it allows the steroid more time to settle down the inflammatory process. But again, it's all conservative therapy, injection therapy, surgery. So you're not just doing the injection in isolation and expecting miracles from it. It's part of an overall management plan. So always scan, always under guidance if you can for a tendon, and protect them 2 to 4 weeks in a boot.
And number of injections per annum. I'm sure I recall a number of 3 being thrown around. What's the latest sort of evidence base between the top end on how much you can pump into someone?
Yeah. So again, it's not been really well done in the literature. Some of it comes from a paper decades ago where a GP injected his wife, and he gave her 41 injections for plantar heel pain. And she strangely developed some soft tissue problems. Shocker. So the rule of thumb is 3 in a year in a weight-bearing area. But it depends on what's happening with the tissues. So I'll go 4 or 5 in a year if I see no changes to the soft tissues, if I'm seeing no atrophy, no loss of pigmentation, and we're still having a clinical effect. But I like to reduce it down. So I have a guy, he's a travel writer, has the job I want, goes away on holiday and gets to write about it. He's got an arthritic talonavicular joint. So that's kind of big surgery. He's coming up to retire. He comes back once or twice a year. He's been doing this for about 6-7 years. And we give him 1 or 2 shots a year just to keep him comfortable. And we've done that for 6-7 years. When he retires, we'll take him to surgery and we'll fuse him. But a petered out dose, relatively low, providing we see no soft tissue changes, is okay. What I don't want to do is 3 a year every year. And, that patient's going to be converted to surgery most likely.
Right. Got you. Craig, I just saw a question come in that might be a good time to ask it now. Where did it go? I think it's from Rob Isaacs, and I think it probably touched on what you were saying at the start with regards to the methodology of some of the research that's done when they take an injection or any injectate versus a placebo. Some people, I'll read it verbatim. Some people do injection therapies with inert substances or LA and attribute some success to prolotherapy principles. The Bill Lighting paper. How much benefit do you think comes via that mechanism of action as opposed to the actual pharmaceutical action of the steroids? You sort of touched on that at the very start. Right. But I don't think Rob was online though. He
was probably too busy singing because he's been booked for a couple of gigs. Oh, he's anyway. Rob Egan. What a great voice. So for anything we do, you've got to have a placebo effect. The fact that the patient comes up and they see you with all those fancy letters after your name and they just think, I'm going to trust that person. So you've got an amount of placebo right from the go-get. And I've not seen that study where we've given somebody a pretend injection, but we haven't given them anything at all. We've actually done it in knee scopes where they've had sham knee surgery. I think we'd have trouble getting that past ethics. So then you've got the effect of any injectate, then you've got the effect of the needle as well. We kind of touched on the peppering. When we're thinking about prolotherapy, although I've not done it, some of the guys who I respect their opinion, people like Otto Chan, who's a radiologist down in London, you've probably come across Otto.
Yep.
He uses that for some of his Achilles. So I think there's something in just the fact there's fluid in there. And when we talk about mixing local anaesthetic with steroid, I think that breaking of the pain cycle has an effect. So one of the things that we don't do enough is think about diagnostic blocks. So I'm a big fan of putting some local anaesthetic in just to see whether that has an effect. So for instance, sinus tarsi syndrome. Somebody comes up and you're not sure whether it's an ATFL or a sinus tarsi syndrome. So you put in a little shot of local anaesthetic in and then see how they go. And that patient will sometimes come back a week later if you don't see them soon. And they've had a therapeutic effect that's lasted beyond an hour from local anaesthetic. The thinking behind that is you get some reactive hyperemia, they're breaking the pain cycle, some of that, all those kinins going in. So I certainly don't decry whatever juice it is. And if you're going to put a juice in, why not use local? And that becomes all part of the magic, which is very then difficult to prove scientifically.
So research-wise, in every single paper that you're aware of, when they've had their control group, the experimental group, the control, they've always physically pierced the skin of the control group that you're aware of.
That I'm aware of, yes.
I mean, because you'd almost really, to try and take the effect of the needle out of the equation, you'd almost need to try and tell them they're being injected, but not physically inject them. You'd obviously maybe put a screen up and touch their skin with something sharp.
Yeah.
You know.
But even you look at the kind of the sham orthotic papers where they put like a little, the thinnest thing in the insole, in the shoe at all. Even that might have a physiological effect. So it's very difficult to completely rule out anything.
Oh yeah, absolutely, yeah.
But I think, you look at the steroids, then clearly these things do have a physiological effect. It's as opposed to a sugar solution, where I think it's a little bit more difficult to say how that actually works. We are dealing with things that you can really look at the chemistry and the pharmacology, and these things do things. Yeah. We certainly see overdoses. Well, we could touch on homeopathy, and what I try not to be is one of those homeopathic podiatrists who just say, "Hey, look, I kind of know it works because I feel it in my heart," and I don't want to be that guy. No one wants you to be that guy. No one wants to be that guy. Well, some do. Some are quite comfortable being that guy.
Well, they are very. Yeah, I agree. Anything else on Facebook, Craig? My phone's just crashed, so I can't see any of the questions.
Yeah, there's a couple of questions there. There's one from Gareth Milne, more of a comment than a question. It's sort of we've got the Cook-Purdom model of reactive versus degenerative tendinopathy, and maybe we need the same sort of modelling for plantar heel pain, the itis versus the osis. And I think so. I mean that kind of makes sense.
Can I just jump in on that, because we talked a little bit about the itis and the osis, and when you look on a 5-year-old plantar heel pain with a 10 mil fascia, and it just looks gnarly on an ultrasound, but you put in one shot of steroid and that patient just becomes pain-free within 2 days, and I've seen it. It's difficult to attribute that to anything other than what you've done. Now, clearly the steroids are anti-inflammatory, so if you've got an osis and not an itis, how does it work on those things? So I struggle with that. So that's where maybe.
But it does bring up another point, and you look around at all these courses on tendinopathy, they always have a section on plantar fasciopathy. Is the plantar fascia have the same characteristics of a tendon? And that's, we could have a whole discussion on that. So,
and even in the inflammation in tendons debate, the tendinitis, tendinopathy debate, they're constantly changing their mind. There's no inflammatory process. Well, there's some inflammatory process. There was a really great paper in the BJSM only like 12, 16, 18 months ago by Ben Dean that said I think it was called tendinopathy, time to revisit inflammation. So it's just, it's in and out of vogue constantly. So it makes sense that...
He's a really nice guy. His surname was Down, but he had to change it for comical problems because,
There we go. Who had... Sorry. We had a sweepstake on the first joke timings going, and I don't know who had that, but I'll make sure they get their prize. Anything else, Craig? There's another one by Gareth Milne here.
Oh, can I just jump in on that point? So as a jobbing surgeon that's opened up a few tendon sheaths, absolutely you open these things up and they are properly inflamed, and you can send off synovium and send it off and it kind of grows in the lab. So again, itis, osis, but having seen them surgically, they are absolutely inflamed on occasion. And the same with hallux limitus, hallux rigidus. You can open these things. We don't think of osteo as an inflammatory arthropathy, but when we go in there surgically, oftentimes there's a lot of pink stuff in there. Many, many times.
It's funny because we all spend all this time debating about the right terminology because of the latest paper we've read, but we really, a lot of the time, we're really not too sure, are we? Let's be honest. Uncomfortable as it is to admit. Gareth Milne, dextrose prolotherapy above 12.5% concentration will create an inflammatory effect in the tissues, releasing a cascade of growth factors. Again, more of a statement than a question there, but anything to add to that?
Yeah, I think when you look at prolotherapy, there's kind of 3 different groups and paradigms they have. The one I've read the most on is the dextrose. Not done any myself, not had any experience of it, but I think there's some mileage in it. I think personally, if it was my tendon, I'd probably prefer some sugar in it than some steroid in it, probably. But I've not done any of that myself, which is a shame because it's an area I'm probably missing out on. I don't, because I'm just a kind of like a jobbing bunion surgeon, I don't see too much sports tendinopathy type pathology in my clinic. Are you injecting, Ian? You must be injecting in your...
No. I have this chat quite regularly because of the way we work in the sort of in the multidisciplinary team we've got. It's more interdisciplinary than multidisciplinary. We've all got our little areas of specialty, and literally 4 steps to the room next door, and there's a consultant sports physician with an ultrasound, and he just does them.
Yeah, so it's a little bit similar to me in my private hospitals. We've got radiologists next door. He'll do the scan, which I want for diagnostic purposes. He'll do a guide injection, and then he'll manage that. So you don't always need to be that guy, do you? No,
and I think, well, there's 2 things. Firstly, the way private practice works, and particularly if they're insured, a lot of the big insurers like Bupa, it's different for you because you're Mr. Surgeon Man, but I'm literally just Joe Podiatrist. So Bupa will pay for a consultant to inject, but not as easily for my kind. So there's all that kind of things that's probably get aroundable, but life's too short. Yeah. But also, like you say, we've got a good team. So, for every kind of injection I palm off onto them, not only do I not get all the worries and concerns about adverse reactions, but I'll get 3-4 patients back to be asked to perform a gait analysis on them. So it's just, I've not really gone down that route because of my setup, but I get why people do. I think it's a great thing to do. If nothing, just for one of the you've probably heard this similar feedback. One of the things I heard about someone who'd a report of your course from someone who'd been on it.
Sorry about that.
I sort of said to them,
because EastEnders is on. Go on.
It's okay. I'm not going to, I've got some bad ones as well if you want, but this was a particularly good one. He said, I don't even know whether I want to do that or I'm going to do that. It really depends on, like I say, geographically where I work or the setup within the clinic you're in. He said, but it's not been wasted time because I learned so much, if nothing else, just anatomically. Just a beautiful refresher on sort of pharmacology, anatomy, 2 things that I know you're pretty, passionate about from our undergraduate days anyway. So I thought that was quite nice feedback. A course that you could go on that you don't necessarily have to want to inject afterwards.
I think I've probably scared a few people off because the last lecture I do is complications and, have a slew of kind of bad outcomes, infections and ruptures and things like that. And, I'd always say, whatever you do well. And if it's not for you, that's fine. Certainly I've put a few people off and they'll just be more aware. So as a jobbing surgeon, I have the advantage of knowing in 3D, for instance, where the fascia is, knowing how deep it is. So when we do some surface anatomy with people or we're doing some dry needling, a lot of the pods that come on, they just don't physically know how deep the fascia is. So you've got to understand that 3D anatomy. And as you know, I'm kind of hot on that because if you don't know your anatomy, you can't diagnose. I see MSK pods coming on the course and they can't even show me where post-tib inserts. So how can you diagnose post-tib dysfunction if you don't know where post-tib actually goes? And, so there's been really good people on the courses and it's really challenging. And every time I come away learning a little bit more, we have some good people come on the course. But a few people, probably it's not a skill that they should look to use regularly in their practice.
We'll talk about the course again in a second. Before we do, just to touch on something you said, we already sort of said that the ruptures really aren't being seen with the frequency that the internet would suggest. What is the most common adverse effect that you see? What is the most common complication? You said infection there, I guess. Or
flare. So
steroid flare. Okay.
10% with the insoluble. So depomedrone, Kenalog, and that flare can be 1 to 2 days of acute pain, i.e., cannot walk, cannot work. I've seen them last up to a week. So really, really sore. Just not fun at all. Had a lady last year had a flare and we had to put her on morphine. So they can be really bad. So every single time I inject somebody for the first time, and it needs to be documented as such, they're warned that there could be a 1 in 10 chance of a steroid flare. You're then looking at things like atrophy, of tissue atrophy of colour, facial flushing, 1 in 100. But if somebody goes, like I've told a really bad joke and I've really embarrassed myself and I go completely red, that for 2 or 3 days, not funny. Problems with a diabetic patient, it'll throw the bloods out for a couple of days, and occasionally with ladies as well, if they're close to the cycle, it can throw them out a little bit if they're towards the end of the month. That's a difficult conversation sometimes to have with women of childbearing age, but it's all in the information that I give out because it's all part of that informed consent process.
Mm-hmm.
Well, steroid flare is the most one. Infection, round about 1 in 1,000.
Okay.
But that can be losing a foot and we losing a toe, a colleague of mine had, and one of my physio friends had a near death from a shoulder infection that was septicemia and was really serious. So absolutely needs to be done under sterile technique, which then needs to be something that you document. Every single time I inject, I recall that it was done under sterile technique, every single time.
Let's quickly touch on PRP, because we've talked about steroids a lot. We've touched on Ostenil and anaesthetics, and we know that you're more than just a steroid guy. All injectates. And Angie's just said, "What are your thoughts on PRP?" I mean, again, doesn't seem to be loads of evidence for that.
No. So you got PRP in the autologous blood. I think the evidence base on these is growing, certainly for PRP. I think there's been some good papers in the last 2 to 3 years. Akram, one of my trainees, he's looking to do his PhD on that if he can get funding. Whether it's going to actually do something to create a bit of magic healing potion, I don't know. Whether it's the injectate or whether it's the needle. But I think that's just in terms of getting access to it. I don't think we've got that anywhere in our county. We've got it in Leicester, never used it, only seen it theoretically. Whereas you can go to the company, you've got dozens of bottles of steroid. So it's probably something we should be looking at more. But then it's going to be, right, is it PRP, autologous blood, steroid, prolotherapy, saline, LA? And then that suddenly you need 10 papers to say which is the one to go for. But I think PRP, I think there's some mileage in it.
I've seen quite a few in London. London's so trendy. Just if something's cool, they're going to do lots of it. But the trouble is, if I've post injection, if they come to see me, it's usually because it hasn't gone well. So completely biased sample, but all I've seen is people that haven't had a good result. I acknowledge that I won't have been seeing the people that have probably had success, but lots of failures over the years.
Well, that brings them into an area that I encourage people to do when they're starting out, is to actually audit the results that you do. So that you need to know for your own experience is what works. And it's another big thing I think with all of the research is take it with bunion surgery, which is kind of like my kind of job in stock in trade. So there's a particular bunion surgery that's in vogue, and all the literature says this is the bunion surgery, this is the go-to procedure. But does that mean that I'm any good at that procedure? It's about your own personal set of skills. And I think it's like that with the injections as well. It's what dose, where you put it, your own particular skills. And so you develop experience if you see the patient's back and go, okay, that didn't kind of work. Or that worked really well. What did I do, and look to repeat it? So properly auditing your results, there's a dozen and one different audit mechanisms on the shelf. Actually do that. Actually just put some in the notes. Even if it's just a simple 10-point VAS. We don't do it enough as a profession. So look to audit your results.
And you find you have to chase them up for that, because it's a very British thing. If things don't go well, rather than go back and complain, you tend to go to someone else. We've all seen each other's failures, as the famous quote. Do you have to actively chase them down for that?
We do. We book them in. So my routine is 6 weeks after an injection. So everybody's getting a 6-week review. Do I actually chase them up if they DNA at 6 weeks? Probably not as often as I should. I went through a phase of doing telephone consults after a week or two to see how they're going. And I think if you're starting out, that's a really good thing to do. What typically happens is, as you say, the unhappy patients will come back. The happy ones tend not to, because, hey, I'm fine, I'm not going to bother going back. So you'll have a day where you think, I'm rubbish, I'm getting really bad results, but actually only because you've got this skewed sample. But if you make an effort to track them down, I think that's a really good thing to do. Yeah.
Okay, let's talk about your course. Not in a really pluggy way, but in a sensible way, in that there may be people listening that think, I've been thinking about doing that, or I wasn't sure, I don't really know what it entails. What's the sort of process between, deciding I've never done this to suddenly I want this in my practice? Or, what's the step-by-step approach?
So, did you hear that pinging? Excuse me.
Was that you?
Yeah, Anne Summers. Oh, okay, I'll speak to her later on.
Is that your stockbroker?
Website, I don't know. So getting access to steroids has changed somewhat over the years. So effectively, we've now got access to one steroid with our LA certificate, and lots of people kind of don't know that. So if you've got your LA certificate, which everybody pretty much has got, you've got access to methylprednisolone as part of that LA certificate. So you can just start injecting depomedrone tomorrow. With some of the things like HA, Ostenil, that's not even a POM, it's a medical device. So you can start injecting those tomorrow. Now, would I recommend that? No, because I do think there's a difference between knowing how to do an ankle block, and then knowing how to inject a fascia, because it's just not something you've done before. So I think there's a third course to become accredited. There's probably about 8 to 10 in the country now. Universities taking it on board, which I think is probably a better thing than lone wolves like me. And they've all been a theory course, and then a kind of a practical mentoring. And I think that's kind of a good way to go. So to look at pharmacology that you've maybe not looked at before, to look at pathology, look at the indications, the contraindications, and then having done that, to spend some time with an experienced injector to go, right, this is where the needle goes. This is the downside. But also to see those patients back. So you see them back after 6 weeks, so they come back and just go, that was amazing. After 2 days, I had no pain. Or I've had a flare and it was a nightmare and I couldn't walk for a week. So most courses are theory and practical. But technically, you don't need it. You can actually jump in with depomedrone now, but I wouldn't recommend it. I don't mean to sound biased there, Ian.
No, of course. So there isn't a set number of injections you need to perform and have a logbook and get them signed.
No, not the depot. You can jump in tomorrow. For other drugs like Kenalog, which you could get under a PGD, they're drug specific. They don't require a specific training. For most of the courses that are being society accredited, then there's different numbers. So most of the courses say you need to do 10 injections, which is a really tiddly number. And I can't do the maths, but I reckon when I was doing lots of injections, I was probably doing about 4 or 5 injections a day, 4 days a week, over a 40-week period, and take that over 17, 18 years. I mean, that's many thousands of injections. So I always say for experience, what I really, really believe is it takes about 50 injections per pathology to really nail it. So that's 50 fascia, 50 Mortons, 50 Hallett's limitises before you really understand how they're going to go. You see all the different permutations of that got better, that got worse, it got a bit better and then regressed. So 50 injections per pathology to nail it.
But there's really no structural sort of pathway to take. If you've got your LA, as you say, as every graduating podiatrist does now, you got your POM and your LA.
So technically, you can go with depot straight away. The accredited society courses, if you want to get insured, so I'm thinking for the private practitioners, then most of the courses out there, it's a bit of theory and a bit of mentoring. So like there's quite a few of the masters modules that they'll run like a week-long injection therapy program, which I think is great. The difficult bit is finding somebody who can mentor you. It's finding somebody who's got the time and the availability. That's where lots of people have struggled.
Yeah. What's it like in Australia, Craig? What's the process for this in Australia?
Yeah, it's complicated and long, so I won't get into it here. But it's a long process to get access to steroids. Obviously, you graduate with access to locals. It's changing slowly, but I won't go that way. It's a long, difficult explanation of the process. Well, okay. Anything else you want to touch on, Craig, on that's come through on the questions? Not really. There's only one question here from Graham Franklin about differentiate the plantar fasciitis from Baxters nerve impingement, and are you going to inject Baxters? I don't know whether you want to comment on that, Ian.
So the second question is yes, absolutely. We will inject Baxters. So one's an osis or an itis. One is a soft tissue pathology. The other is a nerve entrapment. So you're dealing with neuralgia, you're dealing with Tinel's, you're dealing with very much a neurological condition. The location of them is different. So Baxter's nerve is deeper in and more lateral. That's one of the times you want to x-ray, because you'll nearly always find when you do an x-ray of a Baxter's, you've got a heel spur, because it's the heel spur that's irritating the nerve.
Interesting.
I think.
Would you inject that as well?
Yeah, absolutely. Yeah, and the injection is a bit higher up and a bit further across. And big dose, because you're kind of wanting to stretch the area. Results are kind of so-so. There's diagnostic elements to that. If it takes away the pain and you've injected where you think the Baxters is and where the fascia isn't, then there's a diagnostic benefit to the injection.
Nice. Okay, how are we doing for time, Craig? Have we?
Yeah, I think we're 50 minutes. So I think we 50, 50. Yeah.
Wow.
Time goes quickly. You're having fun.
No time for your planned stand-up, Reilly. Come on, give us. Okay, I know you're desperate. You've got an audience of 49 people currently, probably the biggest you've ever had for jokes, at least. Give us 2 or 3. Come on. You've got it written down in front of you. Keep it clean. just in case.
That's it. I'm out. I can't
You've
do
got
it.
no clean ones.
Not a single clean.
That's probably true.
Yeah.
Well, okay, let's wrap it up. Thank you so much. It's a genuine pleasure. You know, we've known each other a long time, and it is a pleasure to talk to you always. So thank you so much for your time. I mean that sincerely.
Yeah. Thanks, Ian. For those there have been quite a few who've just joined in the last 5-10 minutes. You know, if you hang around, this will be rendered on Facebook in about 20 minutes, the whole video. Later on today, Australian time, it will be on our YouTube channel. So please go to our YouTube channel and subscribe so you get notifications.
What about the new website?
And our new website is up. It's been up for a week or two, but it's ready to go live as of a few days ago. So please head over to our website. Just Google PodChatLive. You'll find our Facebook page, our website, and the YouTube channel. On the website, there is an email sign up where you can get, and we'll send it an email whenever we're going to go live, so you get plenty of notifications. So again, thanks everyone for joining us. Thanks, Ian and Ian.